Thank you, Dr. Mueller. And thank you everyone for attending this talk virtually today. My name is Julia Fehniger. I'm a GYN oncologist with Legacy Medical Group. I see patients at Good Sam and at Meridian Park. And I started with our group in the fall of last year, and feel very fortunate to be able to talk to you all a little bit about some of the recent changes in cervical cancer screening guidelines and sort of what consequences that has for us. So just to sort of briefly go over the outline of my talk. So I'll provide a brief overview of HPV infection, cervical dysplasia and progression to cancer. And then I'll spend a little bit more time talking about this paradigm shift in the 2019 cervical cancer screening guidelines, moving from just relying on the results of screening results alone versus risk stratification for to look at the likelihood of underlying severe dysplasia. And then we'll talk a little bit about what the different criteria are for intervention based on a patient's given risk. And then talk a little bit about the ASCCP app, which makes it very easy to kind of figure out what to do next for all these screening tests. And then finish by talking about HPV vaccination, because I think ultimately we'll be able to prevent a lot of these cancers with increased uptake of the vaccine and time. Next slide. So as you probably all are aware, almost all cervical cancers are HPV related. So almost everybody in the population is infected with HPV at some point in their life, usually close to the age at which someone initiates sexual activity. And after infection occurs, the virus itself gets integrated into the epithelial cells of the cervix. And there's this process that can take many years, where after someone is infected, the majority of patients will actually have resolution of the infection and will have negative HPV testing and negative screening. But over a time frame of 10 to 30 years, kind of depending on how aggressive the strain is and the patient's biology, the DNA from the HPV can be integrated into a tumor cell and lead to diagnosis of cervical cancer. Next slide. And so because of this, cervical cancer screening can be done. And it's important because it does save lives, because it can find HPV and early cell changes or precancers many years before they become a cancer. And removal of these precancers or dysplasia does prevent cancer from developing. And screening can also detect cervical cancer at an early stage when treatment is both less extensive and more successful. Next slide. And so even though, we've had cervical cancer screening programs in place for many years, HPV-related cancers are not limited to cervical cancer. So as you see on the right side, there are a number of HPV-related cancers, including anal, oropharyngeal, penile, vaginal, and vulvar cancer. And based on data that was presented last year at the American Society of Clinical Oncology annual meeting, looking at in the United States from 2001 to 2017, there's been a 2.36% increase in HPV-related cancers per year over that time frame. And the highest increases are actually in oropharyngeal and anorectal cancer. And there's been a decrease in cervical cancer incidence, which is great. But when we think about kind of the damage that HPV can do and the consequences that it can have, it's important that we talk about cervical cancer screening, but keep in mind that it's not just about cervical cancer, and that even, for women who are undergoing cervical cancer screening, because of this decrease, anorectal cancer is actually expected to surpass the incidence of cervical cancer in the United States for those who are older than 55 by 2025. Next slide. And so, as you're probably all aware, we learned in our training and just, sort of part of kind of being part of our society. Cervical cancer screening was started with the Pap smear, which is a cytology-based test, which was actually developed in 1941 and then implemented on a very widespread basis in the United States and other countries from kind of 1950 to the 70s. And with this advent and uptake of screening with the Pap smear, rates of cervical cancer have significantly decreased since the early 1900s, and rates continue to decrease, but there's a little bit more of kind of a leveling off in terms of the incidence of cervical cancer. Next slide. And so when thinking about kind of who, when, and how to screen, there's sort of two things to think about. One has to do with a patient's age, and then related to that, how likely are they to have evidence of an HPV infection that's not necessarily going to cause severe dysplasia or lead to cancer, and how to kind of combine cytology and screening for HPV, which we'll talk a little bit more about on the next slide. And there are some nuances, and there are guidelines that are published by the USPSTF that are endorsed by the ASCCP, which is the American Society of that kind of looks at cervical cancer screening and colposcopy, and the American Cancer Society, which updated their guidelines in 2020. And I'm going to spend most of my time for the rest of the talk talking about the ASCCP guidelines rather than the American Cancer Society. We can talk a little bit more about that in the questions if there are specific questions about that. So in general, patients should get screened from ages 21 to 65. For women that are older, so older than 30, that screening should include HPV testing. And for women that are younger than 30, they don't necessarily need HPV testing, but it depends a little bit on what their cytology shows and what their risk factors are. There are different guidelines for patients who are HPV positive or otherwise immunocompromised. And again, HPV testing is important, but not until kind of that initial infection is expected to have been cleared or resolved. So, looking at ages, at least age 25 and more commonly after age 30. Next slide. And so, there's kind of, in the guidelines, it can seem a little bit confusing that there's this combination of cytology and HPV testing. And there are pros and cons of, all the different approaches. This slide kind of highlights some of the, advantages and disadvantages of different screening approaches, whether just doing cytology and then reflexing to HPV testing, depending on what the cytology shows. Co-testing, which means getting cytology and HPV testing at the same time, and then HPV testing itself. HPV testing alone relies less on having a good sample from the squamocolumnar junction, which is, kind of within the cervix. So there may be a role for self-screening and self-collection, which is, interesting and could be adopted in the future, but there are only 2 FDA-approved tests for primary HPV testing, and a lot of our infrastructure for cervical cancer screening is kind of dependent on cytology and less so on primary HPV testing. So the guidelines that I'm going to talk about today don't advocate using HPV testing alone, although I think that this will probably change over time. Next slide. So even though we know that there's effective screening and it does, incorporate HPV testing to, provide, better information for providers and for patients, we know that there's room for improvement in screening uptake. So even looking in the United States, based on a National Health Interview Survey, there was an increase in patients who were overdue for cervical cancer screening that should have been screened from about 15% to 23% of patients in 2019. And we know that with the pandemic and patients not necessarily utilizing healthcare, particularly screening exams, I expect that this will probably be higher for the years 20 to 22. And so not everybody who is getting screened, who should be getting screened is. Next slide. And we know that most patients that are diagnosed with cervical cancer are diagnosed because they haven't been adequately screened. So about 50 to 60% of those diagnosed with cervical cancer in the United States either haven't been screened or have been inadequately screened prior to their diagnosis. And normal screening makes a patient significantly less likely to be diagnosed with cervical cancer. And as you're probably all aware, not surprisingly, patients who are older, have lower SES, those who live in high poverty areas or uninsured are associated with an increased risk of being diagnosed with cervical cancer, partially because of low screening uptake. And we know that there's a higher stage of disease diagnosed in the unscreened population. Next slide. And so this is a screenshot from the guidelines from 2012, which is the last time the ASCCP guidelines were updated. And so you'll sort of probably recognize that there's kind of this algorithm or flow chart for what to follow. And so all of these, the paradigm that was used in prior screening guidelines was really management based on specific results. So it didn't really take into account what somebody's prior results were. And it had a lot of kind of different ways in which you could kind of go. And there sort of the guiding principle was equal management for equal risk. They wanted to make sure that they weren't over treating, but they also didn't want to undertreat. But with increased sort of data from large data sets, including from Kaiser and a number of state-based cancer registries, the ASCCP supervisory committee or task force decided that there needed to be some changes. And so that leads us to the guidelines that were published in 2019. Next slide. So these were published in early 2020, and I'm just going to go through very briefly kind of the paradigm shift that this represented. Next slide. So their organizing principles of the committee were kind of four main ones. So the first one was that knowing that cervical cancer is almost always related to HPV infection, as is severe dysplasia, HPV-based testing should form the basis for risk estimates rather than cytology, and that by incorporating current results and past screening history, you can provide personalized risk-based management utilizing these things called clinical action thresholds, which is sort of like a threshold above which you should utilize either a certain surveillance strategy or a certain management strategy, depending on what someone's result is. And that in a perfect world, guidelines should allow updates to incorporate new test methods like primary HPV testing as they're validated. And then also adjust for the fact that as more of the population is vaccinated against HPV, we think that there are going to be lower rates of CIN3, which is or severe dysplasia, which is a good thing. But the guidelines should sort of adjust for that in their risk estimates. And then because colposcopy, which I'll talk a little bit about in a minute, is really, really important in these guidelines, it should adhere to specific quality standards. Next slide. And so basically kind of the big decision point when you get somebody's screening result when they have their pap test is to this question. So is there immediate risk of severe dysplasia or cancer, so CIN3 plus, greater than or equal to 4%? And so if it's greater than or equal to 4%, you sort of go along the top kind of part of the slide where you look at either doing colposcopy, expedited treatment, which we'll talk about more in the next slide. The idea that if you're higher risk, if you're higher risk, then you should have more aggressive treatment. But if it's lower than 4% immediately, you should look at their risk sort of over the next 5 years and then try to figure out what is the right surveillance interval for this patient. Next slide. So if a patient is higher risk, so if they have an immediate risk of CIN3 or cancer that's 4% or greater, you kind of fall into one of three buckets. So if you are on the lower end of that spectrum, you should get a colposcopy. We'll talk about what that means in the next slide. If somebody is kind of intermediate risk, so either somewhere between 25 to 59%, you have an option of either colposcopy and biopsies or doing expedited treatment. And doing sort of a less aggressive management is preferred if somebody's younger, if they're pregnant, or if they have future fertility desires, given concerns about risk of preterm labor and cervical insufficiency. And then if somebody has a really high risk, so 60 to 100% of having CIN3 or cancer, just based on their screening results, then they should just go skip the colposcopy, go straight ahead to a LEEP or other excisional procedure. Next slide. And so, for those of you that maybe are primary care doctors or don't, routinely do these procedures, I just wanted to talk a little bit about what these management options look like. So colposcopy is basically involves looking at the cervix under a microscope with the assistance of something placed on the cervix to highlight areas that may be abnormal. It's usually acetic acid, which is basically table vinegar in a dilute solution. And then any abnormal areas should be biopsied. This can be done in the office. It's very minimally invasive. It can even be done if somebody is pregnant. And so below we see kind of what some of these changes could look like on colposcopy, sort of progressing from some, HPV infection to more severe dysplasia and cancer. And then an excisional procedure in the office is most commonly something called a LEEP, which is basically where you take this loop that has some electricity kind of connected to it. And then you take a larger portion of the cervix, including the ectocervix and a portion of the sort of inside part of the cervix, in order to be able to get a bigger sample and potentially, treat the dysplasia rather than just getting a biopsy. Next slide. And so then if patients sort of fall into the less than 4% category, we should look at their risk of severe dysplasia or cancer in the next 5 years rather than immediately, to figure out what their management should be. So if their risk is anywhere from 0.55% to 4%, then they should get follow-up in a year with a PAP and HPV test. If it's a little bit lower than that, then they can space it out to 3 years. And if it's even kind of at the lowest risk stratum, which sort of correlates with patients that have normal results, then they can have follow-up in 5 years. And so this makes it a little bit easier to kind of put patients into buckets rather than trying to remember every kind of iteration of their screening that could lead them to need a certain follow-up interval. And so next slide. There are some special populations for whom these guidelines are a little bit more complicated. And so if somebody's younger, then you prefer kind of being less aggressive about their management, because even if their changes are HPV related, you don't want to do an excisional procedure for something that may resolve on its own and for somebody that may want future fertility. So you're going to have a higher threshold for doing an excisional procedure. If somebody's pregnant, sort of the same idea, and likely those patients should be referred to somebody who has expertise kind of managing pregnant patients. In patients that are immunocompromised, that have a higher risk of HPV infection, persistence, and then also dysplasia, they have a lower threshold to need colposcopy. And as I mentioned earlier, patients are, in general, should be screened until age 65. But if for some reason somebody's screened older than that, you should just use these same guidelines. And then after somebody has had a hysterectomy for high-grade dysplasia or adenocarcinoma in situ, the prior guidance said that patients need to be followed with PAP and HPV testing of their vaginal cuff for 20 years. We now know that the risk of developing downstream vaginal dysplasia extends up to 25 years. And so those patients need to get screened every 3 years for 25 years. And then next slide. This is really important, but I think it's crucial that we talk about this, that even if patients are up to date with their screening, if they have unusual signs or symptoms, they need to be seen, they need to have an exam, they may need to have a biopsy or something else. And if you don't feel comfortable as, their regular, their primary care doctor or whoever else, like, please have a low threshold to refer so that somebody who maybe does more of the exams, more of these exams, or is more comfortable with managing, all of these things, they should have additional evaluation. And so this is a lot of information. And even with me kind of summarizing it in this way, it's still complicated and I still can't remember all the different permutations and iterations. And so next slide. There is an app for that. So there's a really nice smartphone-based app, which you have to pay for. It's like, I think, $10. And then there's also a free web-based app that basically allows you to put in a patient's test results and then kind of figure out what you should do next. Next slide. And so, Jen, if you can play the video. So this kind of goes through using the app, kind of tapping what the patient's age is, what you want to do, what their testing results show, and then what you should do next. It's so easy. It incorporates prior screening results, which the prior guidelines didn't do quite to the same extent. And then it confirms that this is what you did. And then it tells you. So it tells you that a patient should get a colposcopy because their immediate risk of CIN3 or cancer is somewhere between 4 and 24%. Hers is only 4.1%, so just above that threshold. But it makes it really easy. So I highly, highly recommend it. And this is a good comment, you do need a new app. So it's a totally different app than the 2012 app. But it's, again, worth every penny. So there's a question from Dr. Lin about post-hysterectomy follow-up. It's supposed to be every 3-year PAP and HPV testing, not just cytology, which is a good point. Okay, next slide. So, it's important for us to talk about, screening, how do we manage these results, this paradigm shift, but ultimately what we hope is that patients, as they kind of are, aging and, had access to the HPV vaccine as kids, will get vaccinated against HPV because it prevents cancer. There are many large kind of database or registry studies, many on like sort of a national basis, that show that just the receipt of HPV vaccinations significantly decreases your risk of developing cervical cancer. And then if you're vaccinated earlier, before you're even exposed to HPV, then your risk of developing cancer is much, much lower, like 95 to 98% lower. Which is really important and a very important message to, remember and to talk to your patients about. Next slide. And so the HPV vaccine that we have in the US, I'm sure you're all familiar with, is Merck Gardasil, which covers 9 strains of HPV. There's more than 150, but most cancers are caused by HPV 16 or 18, which is included in the vaccine. It's FDA approved for boys and girls ages 9 to, or starting at age 9. The recommendation is for 2 doses, starting around age 11 or 12. And then if you have your first dose before age 15, you only need 2. But if you start the series after that, then you need 3 doses. And their recommendation is that everyone should be vaccinated up to age 26. In 2019, they adjusted their guidance to say that there was some evidence that there is protection even among patients that are vaccinated a little bit older than that. So they extended the approval to patients that are age 27 to 45, and that should be shared decision making. And we can talk about this question about the DES exposure after we're done. It's a good one. But to utilize shared decision-making with those patients that start the series later do need 3 doses in order to get adequate protection. And there even is some data, which I think is really exciting, that even after somebody who has had a treatment for cervical dysplasia, so they've already been infected, they've already had those cervical changes that have led to the need for like an excisional procedure, even if you offer and give them the vaccine afterwards, the risk of developing severe dysplasia afterwards and presumably cancer is still significantly decreased. So I think it's something that we probably underutilize and should be, doing a better job of talking to patients about. Next slide. And so this is just kind of a cartoon looking at HPV vaccination rates across the country. So Oregon and Washington are doing okay. Adolescents that are up to date on their vaccination series as of 2019 in Oregon is about 60% and a little bit lower in Washington. This data set estimated 53%. I've seen others that show that it's closer to 60%, but it's definitely not universal, and it's definitely not kind of as high as we would like it to be. So we have room to go, but it's still good that people are getting vaccinated. Next slide. So I know this was a lot of information, but I wanted to leave some time for questions and to go over this clinical decision workflow that Legacy has implemented. So in summary, almost all cervical and other cancers are HPV related. Patients that are screened, the goal is to detect and treat precancers. The guidelines now, as of 2019, use the risk of underlying severe dysplasia to triage screening results. The app takes the guesswork out of determining next steps. It's really good. And then ultimately, we hope that HPV vaccination will eradicate both severe dysplasia and invasive cancer.
Sally, do you want to go down the list of questions?
Yes, I am ready. So the first question is, what about patients with in utero DES exposure? Yes, there are fewer and fewer of them, but how should we screen them?
So that's a great question. So similar to patients who have HIV or other immunosuppression, they should be followed basically throughout the course of their lifetime, and they ideally you would see them annually in order to really get a good vaginal exam, and then also to screen them as well. I don't think that they need their changes, their cancers that they develop aren't HPV related. So I don't know that you necessarily need to be doing, HPV testing every year, but I think at the very least, an exam, and not stopping at age 65. I think that's probably a big difference. So.
Awesome. Okay, next one. When you are addressing screening with patients in general, e.g. meeting a new patient, is it standard to ask about DES? Let me finish. Of course, we would likely already know about HIV or other immunocompromising conditions. I've never yet encountered a patient who divulged DES. Thanks.
I mean, that's a good question. Our office doesn't have it like on our standard work, like our patient questionnaire, but I don't know. I think it probably is a little bit of a practice kind of judgment call, just because there are very few of those patients, and they're all probably at least in their 60s at this point. Given that it was mostly used like in the 50s, so I don't routinely ask about it, but maybe I should be.
All right, thank you. And then should we be getting HPV reflex testing on ASCUS PAPs in patients younger than 30?
So, the guidelines actually are helpful in terms of kind of telling you what to do about that. So, I wouldn't routinely recommend getting, I think reflexing to it is reasonable, but I wouldn't get it as part of kind of co-testing.
Okay, and if we get results back from co-testing saying no endocervical transformation cells present, but negative HPV, would you advise retesting?
So that's a good question. So there's actually some language in the guidelines that inform that. So basically, they say that if a patient is age 21 to 29, if their cytology is otherwise negative, then just do routine screening. And then for those that are 30 or older, it, recommends doing HPV testing. And then if for some reason you don't do HPV testing at that point, like if you just do cytology, then you can just repeat cytology in 3 years.
Perfect. I find I get no endocervical cells sometimes, even when I've thought I've been very thorough with the swab. Any recommendations?
I feel like they always come in a little bit in waves, right? I don't know that it necessarily, I don't know that I have any magic. Some people talk about, not using a lot of lubricant with the speculum and just using water. But I don't know of any sort of evidence-based tips. Maybe somebody else who's in the meeting has, some better suggestions.
The next one is I manage kidney transplant patients. My understanding is that they should have co-testing every 3 years without an upper age limit. For average risk patients with adequate prior screening, do you see any role for continuing screening after age 65?
Okay, so those are 2 great questions. Yes, the answer to your first question is yes. They should never stop getting screened because they have a risk of dysplasia, just sort of as long as they're on immunosuppression. And then for, the question of what to do for, patients that are older than 65, in general, we talk about if somebody has a life expectancy of kind of at least 10 years, which almost all patients that are older than 65 do, then it's reasonable to sort of talk about risks and benefits. I think it really depends on the specific patient and, what their history is. And I think we're always going to diagnose some cancers in women who are older than 65. But I don't know that necessarily screening everybody, given like the long lead time, and the fact that in order to exit screening at 65, you have to have like a well-documented history in the preceding like 5 to 10 years of having normal screening results. So I think would be an area for shared decision making.
Who should be managing a patient with high-risk HPV? For example, 16. I referred a patient to Gyn who had high-risk HPV. She had colposcopy and was told to follow up with PCP. And the following year, she had HPV 16 again, needs another colposcopy. Shouldn't the patient continue care through Gyn until this abnormal is resolved?
That's a tough one. I think, given that HPV is 16 and 18 are the most sort of oncogenic strains of HPV, there's definitely a higher risk of needing to have colposcopy or biopsies or excisional procedures. I think it probably, would be worth a conversation with whoever you refer to in terms of figuring out kind of a plan as part of the patient's care team to figure out what makes the most sense moving forward. And it probably should be a little bit individualized. And I would, in the question about the HPV vaccine for unvaccinated patients who are going to have a transplant, even if they're older than 26 years old, we don't have data for that, but I would say that if it's covered by insurance, and I think it probably depends, and I don't really, I'm not an expert on that part of it. I think it's reasonable because I don't really think there's any downside to doing it. It might provide some protection.
All right. And what are your thoughts about the postmenopausal patient who has completely normal PAP, HPV testing, but then in her 50s, 60s gets a positive HPV, negative 16, 18, negative PAP test, and HPV is persistent for 2 years. They have colposcopy at most CIN1, HPV clears, comes back.
So we don't really know. We don't really know if this is like reactivation or reinfection. My thought is that, if somebody doesn't have a new sexual partner or other like new risk factors, it's probably some sort of reactivation, but it's unlikely to cause severe dysplasia or cancer, which is sort of the goal of screening. But these can be a little bit frustrating and difficult to manage because that they're low risk, but then you also want to be sure that you're being thorough. So it requires some extra work, even though you're probably not going to end up with cancer or CIN3, regardless of what you do.